All right, let's talk about something that's at the heart of every single DOT medical exam for commercial drivers with diabetes. There's this kind of hidden conflict, a world where the normal rules of medicine get flipped on their head. And if you don't understand that conflict, you can't get it right.
So let me start by asking you a question. Picture this. You've got two drivers. The first one has an A1C of 10%. Now, that's a number that would make any family doctor pretty nervous. The second driver, they've got a picture-perfect A1C of 6%. So from a public safety view, who's the safer bet on the road?
Now, if you immediately jumped to the driver with the 6% A1C, well, that's completely logical. You're thinking like a clinician. But here's the twist. In the world of Department of Transportation medical exams, that's actually the wrong answer. Let's dig into why. This whole complicated issue really boils down to one simple thing, a clash between two very, very different goals. Are we worried about long-term health, or are we worried about immediate safety on the road? Think about it like this. On one side, you've got your primary care doctor. Their job is to focus on your long-term health, making sure you don't have complications 10, 20 years from now. But the DOT medical examiner, they have a totally different mission. Their job is all about public safety today, right now. They're not focused on your future health. They're trying to prevent a sudden, catastrophic event from happening behind the wheel of a truck. And this table really breaks down how different those two worlds are. In clinical medicine, you've got A1C targets. But for the DOT, there's no such thing as an A1C cutoff. It is not a pass-fail number. Now, look at hypoglycemia, low blood sugar. For a doctor, it's important, sure. But for the DOT, it is the absolute number one top priority. Any severe episode is a huge red flag. So let's really get into why the DOT is so obsessed with hypoglycemia. And I mean obsessed, for a very good reason. It is without a doubt the single biggest immediate danger when it comes to a driver with diabetes. And we're not just talking about feeling a little shaky or getting hangry here. The DOT's definition of severe hypoglycemia is incredibly specific. The key things to remember are requiring assistance from someone else, losing consciousness, or having a seizure. This is an event where the driver completely loses control of their body, let alone a massive commercial vehicle. The consequences of an event like that happening behind the wheel are, to put it lightly, terrifying. This isn't something that happens gradually. It can be a sudden, total loss of function. We're talking sudden confusion, terrible judgment, and completely losing control of the vehicle. Any one of these can lead straight to a horrific accident. And that's why the entire system is built to prevent this. Okay, so if hypoglycemia is the big bad wolf here, where does that leave A1C? The number that everyone always seems so focused on. Well, the DOT looks at it as just one piece of a much bigger puzzle. It gives them context, but it is not a command to certify or disqualify anyone. This quote right here, this is the key. You should probably write this down. A1C tells you about stability over the long haul. It's an average. What it doesn't tell you is if a driver is having sudden, dangerous drops in blood sugar. That's why their history of hypoglycemia is the real safety marker. Let's circle back to our original question. Here's driver A with that quote-unquote bad A1C of 10.2%. But, and this is the key part, he's stable and has no history of low blood sugar. Then you have driver B with a perfect 6.2% A1C. But that super tight control is causing problems, he's having frequent lows, and one of them even happened while he was driving. So, from a DOT safety perspective, who's safer? It's driver A. Hands down. His condition, while not great for his long-term health, poses way less of an immediate risk to you and me on the road. So this table shows you how a smart examiner actually uses the A1C number. Yeah, if it's really high, over 10%, they might think about a shorter certification, just to keep a closer eye on things. But here's the part that really surprises people. Look at the bottom row. An A1C below 6% is actually a reason to ask more questions about low blood sugar because it might mean their treatment is too aggressive and risky. Okay, so that's the theory. But how does an examiner actually put all of this into practice during a real exam? While the evaluation follows a really clear logical path, it starts with the driver's treatment. But I want you to look closely at step 2. Ask about hypoglycemia. This right here is the whole ballgame. It is the most important step. It's only after they've assessed that immediate risk that they move on to everything else, complications, stability, and finally, using that A1C for context before they decide on the certification. Now, the kind of medication a driver is on actually creates two totally different pathways in the regulations.
So whether they're on insulin or not changes the paperwork and the process, but the goal, safety, is exactly the same.
For drivers who use insulin, the rules are very, very specific. They have their own federal regulation. They need to have a special form, the MCSA 5870, filled out by their doctor, and their certification is capped at 12 months. But for non-insulin drivers, it's different. They're evaluated under more general standards, there's no special form, and they can potentially get a longer 24-month certification. This number right here is a huge takeaway, 12 months. That is the absolute longest certification any driver on insulin can get. Period. No exceptions. It's a built-in safety check to make sure they're reviewed at least once a year. So let's put it all together. Here are the most common mistakes that people make. Think of it as a checklist of what not to do. And you'll notice every single one of these goes back to our main idea. Don't just fixate on the A1C. Make hypoglycemia your number one priority. Check for complications that actually affect driving. And always, always follow the specific rules for insulin users. And that brings us right back to where we started, to that central question. For everyone involved in this process, the driver, their doctor, the medical examiner, this is the mindset you have to have. The goal isn't just about managing a disease. It's about a razor-sharp focus on one single thing, making sure that every single time that driver gets behind the wheel, they are safe, and so is everyone else on the road.